Cold hands, cold feet. You have probably said it to someone, or heard it said, so many times that the phrase has become almost meaningless. A joke, a personality trait, something you are just like. You dress in more layers than everyone else in the room. You reach for the extra blanket before anyone else is thinking about it. Your hands feel like ice after a short walk on a mildly cool day. People take your hand and pull back slightly at the temperature of it, and you laugh and say something like "you have always been that way," and the conversation moves on, and the cold persists, and nobody ever tells you what the cold is actually telling you, because the assumption, the deeply comfortable cultural assumption, is that cold hands and feet are just a personality type, a quirk, a constitutional tendency, an inherited disposition from a cold-natured parent or grandparent. And that assumption is precisely why the biological event that cold extremities in adults most commonly represents, particularly in adults over 45, goes unrecognized until the vascular damage it signals has been accumulating for years in silence. The question that nobody asks when someone says they always have cold hands is this: why are the hands cold? Not in the conversational sense of "why does this keep happening?" but in the anatomical, vascular sense. What is the physical reason that the extremities remain cold when the core of the body is warm? Because the answer to that question, when it is understood properly, transforms a casual personality observation into one of the most accessible and most overlooked windows into the health of the arterial system. Cold hands and feet are, in a significant proportion of adults who experience them chronically and regardless of environmental temperature, a peripheral perfusion problem, a blood flow delivery problem. A signal from the vascular system that something is impeding the delivery of warm, oxygenated blood to the tissues at the body's most distant points. And the most common vascular reason that this delivery is impeded in adults over 50 is a narrowing of the arterial supply to the extremities through a process that is simultaneously the most prevalent and the most under-discussed progressive cardiovascular condition in the modern world. If understanding the real story behind a symptom you have been living with for years is the kind of health conversation you have been looking for, hit like and subscribe right now. Dr. Victor Lang built this channel to have exactly this conversation, and what follows is the full biological explanation of what cold hands and feet may actually be signaling in your vascular system. Let us establish the normal physiology first, because the deviation from normal is only understandable in contrast to it. The body's thermoregulatory system is designed to prioritize the warmth of the core organs above all else. The brain, heart, lungs, liver, and kidneys require a precisely maintained temperature range to function properly, and when environmental or physiological conditions threaten that core temperature, the body responds by reducing blood flow to the periphery, specifically the hands, feet, fingers, toes, and ears, redirecting that circulation toward the core where it is most needed. This peripheral vasoconstriction is mediated by the sympathetic nervous system, which signals the smooth muscle in the walls of the arterioles, supplying the extremities to contract, narrowing the vessels, and reducing blood delivery to the surface tissues. The hands and feet become cold because less warm blood is reaching them. When the environmental temperature rises or the physiological stress resolves, the vasoconstriction releases, blood flow to the extremities is restored, and the hands and feet warm back to normal. This is entirely normal and entirely appropriate. The problem arises when this warm-up does not happen correctly, when blood flow to the extremities fails to restore adequately, even when the body is warm and comfortable, and there is no physiological reason for continued peripheral vasoconstriction. When the hands and feet remain persistently cold, particularly in indoor environments at comfortable temperatures, in people who are warmly dressed and not under physiological stress, the thermoregulatory explanation runs out, and what remains as the explanation is a structural one. The arteries and arterioles supplying the extremities may be narrowed to a degree that limits blood delivery, even under conditions that should allow full vascular opening. The vascular condition most commonly responsible for chronically cold extremities in adults over 50 is peripheral arterial disease, the progressive narrowing of the arteries outside the heart and brain, primarily affecting the arteries supplying the legs, feet, arms, and hands. Peripheral arterial disease develops through the same atherosclerotic process that affects coronary arteries and carotid arteries, the process of cholesterol-rich plaque accumulating inside the arterial walls, thickening them, reducing the diameter of the channel through which blood flows, and stiffening the vessel in ways that impair its ability to dilate in response to demand. When the arteries supplying the lower extremities are progressively narrowed by this process, the resting blood flow to the feet is reduced. The feet are cold because not enough warm blood is reaching them to maintain their temperature, regardless of how many socks or blankets are applied to the exterior surface. The warmth needs to come from within, carried by the blood, and when the blood cannot flow adequately through narrowed arterial channels, the coldness that results is not a thermoregulatory response. It is a circulation deficit. What makes peripheral arterial disease such a significant and underappreciated condition is the connection it reveals between the vascular health of the extremities and the vascular health of the organs whose arteries cannot be seen or felt from the outside. The atherosclerotic process that narrows the arteries of the legs and feet is the same process, driven by the same underlying pathology, that narrows the coronary arteries of the heart and the carotid and cerebral arteries supplying the brain. Studies consistently show that people with peripheral arterial disease have significantly elevated risk of heart attack and stroke compared to the general population, not because the leg artery disease causes the cardiac or cerebrovascular events directly, but because the presence of significant peripheral arterial disease is a reliable marker that the atherosclerotic process is systemic and advanced enough to be affecting the coronary and cerebrovascular arteries as well. The cold feet that have been attributed to personality or constitution may be the most accessible surface manifestation of a cardiovascular process that is simultaneously narrowing vessels in locations whose early compromise has catastrophic consequences. Raynaud's phenomenon is the second major vascular explanation for chronically cold hands, particularly when the cold is accompanied by a specific color change sequence in the fingers: white, then blue, then red, as blood drains out, then deprives the tissue of oxygen, then rushes back in when circulation is restored. Raynaud's phenomenon, which can occur as a primary condition without other disease associations, or as a secondary phenomenon associated with autoimmune diseases, including lupus, scleroderma, and rheumatoid arthritis, involves an exaggerated vasospastic response of the small arteries of the fingers and sometimes the toes. The arteries contract severely and disproportionately in response to cold or stress, dramatically reducing blood flow to the digits. While primary Raynaud's is generally benign, secondary Raynaud's associated with autoimmune conditions can be severe, can cause tissue damage from prolonged ischemia, and represents an active inflammatory vascular condition that warrants clinical management. Chronically cold hands in someone with any other joint, skin, or systemic symptoms should raise the possibility of secondary Raynaud's and prompt evaluation for underlying autoimmune or connective tissue disease. Anemia is the third significant vascular explanation for persistent coldness in the extremities, and it is important enough to name specifically because it is both common and frequently unrecognized as a cause of the symptom. Red blood cells are the oxygen-carrying components of the blood, and their capacity to deliver oxygen to peripheral tissues depends on both the quantity of red blood cells in circulation and the hemoglobin concentration within them. When red blood cell count or hemoglobin is reduced, the blood's oxygen-carrying capacity falls. Peripheral tissues, particularly the extremities, which are the last to receive oxygen-rich blood in the circulatory hierarchy, receive less oxygen than they need to maintain normal temperature and function. The result is coldness and pallor in the extremities, often accompanied by fatigue, breathlessness on exertion, and a general sense of inadequate physical reserve. Iron deficiency anemia is among the most common nutritional deficiencies in adults, particularly in women, and is easily corrected when identified. B12 deficiency anemia, as we have discussed in the context of neurological symptoms on this channel, is also common in older adults and produces the same peripheral coldness through the same oxygen delivery impairment. A complete blood count is among the simplest and most informative blood tests available, and should be part of the evaluation for any adult with persistent unexplained coldness in the extremities. Hypothyroidism adds another layer to this picture that is important and frequently underdiagnosed. The thyroid hormones regulate metabolic rate throughout the body, including in the smooth muscle of arterial walls, where thyroid hormone influences vasomotor tone and the responsiveness of vessels to thermoregulatory signals. When thyroid function is low, metabolic rate falls, heat production decreases, and the peripheral vasoconstriction that is normal in cold environments becomes more pronounced and less readily reversible in response to warmth. People with hypothyroidism often describe feeling perpetually cold in a way that is qualitatively different from ordinary cold-natured constitution, a coldness that persists even in warm environments and that does not resolve with additional layers. TSH testing, the standard thyroid screening measurement, identifies hypothyroidism readily, and thyroid hormone replacement therapy normalizes both metabolic rate and the peripheral thermoregulation that depends on it. The autonomic nervous system dysfunction that can develop in the setting of diabetes and diabetic neuropathy represents a fourth mechanism for cold extremities that is specifically relevant for older adults with metabolic dysregulation. The autonomic nerves governing peripheral blood vessel tone, which coordinate the normal vasodilation and vasoconstriction responses of the skin's blood vessels to temperature change and other signals, are among the nerve fibers most vulnerable to the metabolic damage of chronic elevated blood sugar. When these autonomic fibers are damaged, the normal reflexive vasodilation that brings warm blood to the extremities in response to warmth and comfort is impaired. The blood vessels of the feet cannot open fully when they should, because the nervous system signals that would normally trigger that opening have been compromised. The feet remain cold not because the arteries are structurally narrowed, as in peripheral arterial disease, but because the nervous system control of the arterial tone has been disrupted by diabetic neuropathy. This autonomic vascular neuropathy often coexists with the sensory neuropathy that produces the tingling and numbness we discussed in the foot symptoms video on this channel, and the presence of both symptom categories in the same person suggests a more advanced neuropathic process that warrants comprehensive diabetic vascular evaluation. Now let us talk about what the research shows works to address the underlying mechanisms driving cold extremities, because this is where the information transforms from concern into direction. For peripheral arterial disease, the interventions that most consistently improve peripheral blood flow fall into three categories: those that address the underlying arterial narrowing, those that improve the functional efficiency of the remaining vascular supply, and those that build collateral circulation to supplement compromised main arterial channels. In the first category, the evidence for dietary pattern modification as an intervention in peripheral arterial disease is substantial. A Mediterranean-style dietary pattern, emphasizing olive oil, fish, legumes, vegetables, and limited processed meat and refined carbohydrates, has been shown in longitudinal studies to slow the progression of atherosclerosis in peripheral arteries and to reduce the ankle brachial index decline that marks worsening peripheral arterial disease. Omega-3 fatty acids from fatty fish specifically reduce triglycerides, reduce platelet aggregation, and improve the flexibility of arterial walls in ways that collectively support peripheral blood flow. The polyphenols in olive oil, including oleocanthal and oleuropein, have anti-inflammatory and endothelial protective effects that address the arterial wall inflammation driving plaque development. In the second category, the evidence for specific nutrients that directly improve the functional efficiency of the existing vascular supply is compelling and underappreciated. Nitric oxide, as we have covered in multiple contexts on this channel, is the primary vasodilatory signal that allows arteries to widen in response to demand. In people with peripheral arterial disease, nitric oxide production from the damaged endothelial cells of narrowed arteries is significantly reduced. Dietary nitrate from beets and leafy greens, which restores nitric oxide availability through a pathway that bypasses the damaged endothelial cells entirely, has been documented in clinical trials to improve walking distance and exercise tolerance in peripheral arterial disease patients by improving the efficiency of the remaining blood flow through vasodilatory mechanisms. L-arginine, the amino acid precursor to nitric oxide through the endothelial nitric oxide synthase pathway, has shown similar peripheral circulation benefits in clinical research. Ginkgo biloba extract, specifically the standardized preparation EGB761, has one of the most extensively documented evidence bases of any natural compound for peripheral arterial disease, with multiple randomized controlled trials demonstrating significant improvements in walking distance and a reduction in claudication pain, effects attributed to both the vasodilatory and the platelet aggregation inhibiting properties of the ginkgolide and flavonoid compounds in the extract. In the third category, the role of supervised exercise therapy in building collateral circulation is among the most robustly evidence-supported interventions in the entire field of peripheral vascular medicine. When regular walking is performed by people with peripheral arterial disease, even when the walking produces claudication pain, the repeated ischemic stimulus to the leg muscles promotes the growth of new small blood vessels, the capillary and arteriolar networks that supplement the supply from the compromised main arteries. This angiogenic response, the same capacity for new vessel development we have discussed in the context of leg circulation more broadly, is specifically stimulated by the walking to claudication and recovery pattern that supervised exercise programs use deliberately. Studies comparing supervised walking programs to stent procedures for mild to moderate peripheral arterial disease have found comparable or superior outcomes for walking distance and functional capacity from the exercise program, which represents a remarkable finding about the body's capacity to generate its own circulatory compensation when given the right stimulus consistently. For Raynaud's phenomenon, the most immediately effective non-pharmaceutical interventions involve thermal protection and the avoidance of vasoconstrictive triggers, keeping the hands and feet warm at all times, using chemical hand warmers in cold environments, wearing gloves before touching cold surfaces, and avoiding the sudden temperature transitions that trigger vasospasm address the symptomatic management of primary Raynaud's effectively for many people. Magnesium, which relaxes vascular smooth muscle through calcium channel antagonism, has shown benefit in some clinical evaluations of Raynaud's management, as has fish oil through its effects on platelet aggregation and vascular tone. For people with secondary Raynaud's associated with autoimmune conditions, the management necessarily involves addressing the underlying inflammatory disease, and pharmaceutical intervention is typically required. For cold extremities driven by anemia, iron or B12 repletion as appropriate addresses the root cause directly and reliably. For hypothyroid-driven coldness, thyroid hormone replacement produces rapid and usually complete resolution of the thermoregulatory symptoms. For autonomic neuropathy-driven coldness in diabetes, optimizing blood sugar control is the most important intervention, alongside the B12, alpha-lipoic acid, and acetyl L-carnitine supplementation that supports peripheral nerve health and autonomic fiber function. There is a moment that comes in the life of many people with chronic cold extremities when they stop noticing them. Not because the coldness has resolved, because the adaptation has become complete. They have reorganized their wardrobe, their travel habits, their seating preferences, their social patterns around the management of a symptom that has been present so long, it has become the landscape rather than the feature. They have forgotten that there was a time before the coldness, or they have been told so many times that it is just the way they are that they have stopped asking whether there is a reason and whether it can be addressed. This is the quiet tragedy of a symptom that signals something biological, but is heard as a personality description. The cold that persists year-round, in warm rooms, in appropriate clothing, is not a personality. It is a perfusion deficit. It has a vascular, hormonal, hematological, or neurological cause that can be identified and that can be specifically addressed. And the person who lives with it without ever seeking that identification lives with an unanswered question in the biology of their own body. A question that may have implications for their cardiovascular health, their hormonal health, their metabolic health, or their neurological health that extend far beyond the discomfort of cold hands. You deserve to know the answer to that question. The cold that has been normalized is not necessarily normal. And the difference between asking why and accepting it as just how things are is sometimes the difference between catching a vascular, thyroid, or hematological condition at the stage where it is most amenable to intervention and encountering it later in a context where the options are narrower. Tell me in the comments how long your hands or feet have been cold and whether you have ever been given a real explanation for it. Tell me whether any of the causes we covered today resonated with something in your own health history. Your experience matters here because the person reading your comment may be in exactly the position you were before watching this, accepting something as inevitable that is actually a signal worth investigating. And please share this video with someone in your life whose hands are always the coldest in the room and who has never had someone sit them down and tell them what cold extremities actually say about vascular health. Because that conversation may be one of the most important health conversations they ever have, and now you can be the one to start it. Coldness is never just coldness. It is distance from the source, and the distance has a reason.